Welcome to the Plastic Fantastic podcast, brought to you by Mr. Adrian Richards and myself, Alison Telfer. Adrian is one of the UK's most experienced and eminent plastic surgeons specialising in cosmetic breast procedures. Myself, I specialise in all things to do with cosmetic non-surgical procedures. Each week, Adrian and I will be entertaining, interrogating, laughing and chatting with a whole series of guests. Anyone really who is fantastic and either works within or has been touched by our industry. And today I'll hand over to Adrian.
So hello everyone, Alison and I are absolutely delighted today to be welcoming our good friend Taimur Shoaib to the podcast.
Good morning, how are you?
Yeah, we're good.
Well,
how are you, Al?
Yeah, fine.
So Al,
Really
do you want to
good.
kick off?
Yeah, so Taimur and I probably met, I don't know, similar time with you, Adrian, but we probably met around 6 or 7 years ago, I would say, when we started doing a lot of Allergan work. And the reason I wanted us to have this time with Taimur is because phenomenal plastic surgeon and phenomenal non-surgical, and that isn't always common found in this. But let's get a bit of background, Taimur, because I know you as that, but I've read here, we've read here, you started life in Pakistan, but you don't sound like that's the truth.
No, I moved to London when I was 2 years old, and I lived in London until I was about 9, and I've lived in Scotland ever since, apart from 3 years when I was in Oxford. And so I suppose they never kicked the English accent out of me when I moved to Scotland.
Yeah, because you're very unusual accent-wise, because you've got such a broad. How would you describe the accent, Alison?
I thought it was Scottish.
Yeah, so some people from England will say, "Oh, I can hear your Scottish twang," and people from Scotland will say, "Oh, I can hear your English. I can hear your English accent." It's hard to place. Some people have said, "Oh, from Birmingham."
Yeah, yeah, you do sound like that. So tell us. So you were born in Pakistan, Taimur, were you? And did your parents come to England? How did that work?
Yeah, my dad was in oil, so he moved to London because he was offered a job with an oil company, and then obviously the British oil is in Scotland, and so the company that he subsequently worked for moved their headquarters into Scotland, so that's how we moved.
Yeah. And then medical career and things, Taimur, where did you train?
Well, I did my schooling in Glasgow, and Glasgow University is obviously a nice university for medicine. And so I applied to Glasgow University. I got in, and I carried on my training for my basic surgical training for the first year and a half or so in Glasgow and the surrounding areas. And then surgical training was changing at that time.
I was going to say, I'm just looking at this. What made you go into medicine, though? Because there wasn't that in your heritage.
No, one of my aunts is a doctor, but she worked for the United Nations, and she was part of their population control fund. But and one of my aunts is a gynecologist. But there's not a lot of doctors in my family, and I suppose I was interested in medicine just because I suppose I was interested in the science subjects. I spoke to my teachers about it. I spoke to my parents about it, and it seemed like something I'd be interested in doing.
And Taimur, why? So you did your basic medical training. Why plastic surgery? When did you realise that was what you wanted to do?
I remember as a medical student, I went up to one of our consultant surgeons, and his question was, "Is there anything you guys have not seen that you would like to see?" And I said, "Well, I haven't seen any plastic surgery. We've seen all the other surgical specialties, but we haven't seen any plastic surgery." And he said, "Okay, I'll send you to Canningsburn for the day." So we went to Canningsburn for the day, and we just there were a group of 5 of us, I think, and we just spent a day with them. And I thought, well, this is quite interesting. So when I graduated and started working in surgical departments, I applied for a job at Canningsburn, and that's when I started seeing what plastic surgery really involved. And I was very interested in hand surgery because I think there's a lot of care and attention, and it's meticulous surgery. It's very fine surgery. The hand is a work of art, an anatomical work of art, and there are a lot of structures that are important for its function, and they fit together beautifully. So I thought this is something that I'd like to do. So I then applied for the surgical rotations that were then coming online because surgical training was changing. And I was successful with the Oxford surgical rotation. So I did some plastic surgery in Oxford. And that's where I saw some head and neck surgery and saw some skin cancer surgery. And I thought, well, this is actually very interesting. And I thought with head and neck cancer surgery, I thought this is difficult surgery. I don't think it'll take you a long time to be very good at this. And so I thought this is something that appeals to me. And it appealed to me in the wider context of plastic surgery, where I think I saw a degree of meticulousness in surgical style that I thought I would like to replicate, and I would like to be that kind of a surgeon.
And do you think you are, so something we're finding, I think, with plastic surgeons, they tend to be quite visual people and tend to be quite meticulous about the way things look. You know, would you say you are that type of person, Taimur?
Yeah, I'm sorry, I maybe not have ironed my shirt as best as I could. Put on a tie and look at how untidy my room is. But yeah, I mean, I think we do have this visual neurolinguistic programming inside ourselves, don't we? We're visual people, much so perhaps than some other people are.
Yeah,
I think visual and creative. I think that's the difference, because as we've talked to other surgeons, it's interesting, you did hands, every plastic surgeon seems to have at some point done some hand work. But I think what's interesting about it is that you have to have this creative eye. And unlike, I guess, every gallbladder being the same operation, when you're doing plastic surgery, everyone's slightly different, and what you're dealing with and all of that is slightly different. So I think that's what makes it different. And you have to have that within you, I'd have thought. You can't teach it.
no.
I think that's correct, because there is when we're doing reconstructive surgery, and that's how we all start in our training. We start planning reconstructive work, and we have to visualize. We have to understand how tissues will stretch and bend, and how they will move, and where they will move from, where their pivot points are. And I think these are the things that we think about in our plastic surgery training.
Yeah.
Sure.
Okay, so Taimur, so you are quite unusual in the plastic surgical world, aren't you?
Is that from what Alison was saying? Because of what she was saying, in that I do a little bit of surgery and I do a little bit of non-surgical treatments as well.
Yeah, so you've got the rare combination. It's quite a rare combination of being excellent technically, non-surgical and surgical, and also a good businessman. So a good clinician mirrored with a good business brain. And I think it would be really good, Alison, to dive into that a little bit.
Okay, so I guess what the things we should talk about that I think would be really interesting is, one, why, so plastic surgery, what was it that there were limitations there that made you want to do more non-surgical? What brought that interest?
Well, I suppose when I started as a consultant, my patients were saying to me, well, you're a head and neck surgeon. I want a head and neck surgeon to do my facelift, my rhinoplasty, my eyelids. And then after I did them, a number of them said, well, now I want you to do my Botox, now I want you to do my fillers. And there were a number of patients where I did body surgery, such as breast augmentation or liposuction or something like that. And they would say, you know, yeah, you did my breast augmentation. I'm very happy with the results. Can you do some fillers for me? Can you do my lips? Can you do my Botox? And so the workload became higher and higher, and it became to such a degree that I was running out of space to do my treatments in the private hospital, because obviously I was doing part-time private practice and full-time NHS practice at that point. And I asked the private hospital in which I worked for more space and more availability in the rooms, and they said there was none left. And at that point, I said to the head of the private hospital, well, in that case, would you mind if I opened up my own clinic where at least I can see my patients and I will bring them all into the hospital to perform surgery? And that's when I employed a nurse to contact all my patients. And she said, do you know, I am Mr. Shoaib's cosmetic nurse. If you need any information about your surgery, about your aftercare, give me a call. Normally I do Botox and fillers, but I am your point of contact for his patients. And about a third of them said, oh, well, can I get an appointment for some Botox and fillers? So this is how my non-surgical workload started. And of course, a lot of these patients would come to me, and a lot of the patients would go to the nurse that I employed. And we did the non-surgical work together, and it grew from there.
Quick thing I don't understand. What's a full-time job in the NHS and then a part-time? Because how can you do a full-time and a part-time? That's more than time.
Yeah, so I think full-time in the NHS is around about 48 hours, 40 to 48 hours. And as a result of that, we have busy weeks and we have quiet weeks. So if you're on call for a few days at a time, for example, then you've clocked up quite a few hours. And so you wind up having a lot of free hours the following week or the week after, depending on.
Yeah, can I explain this one? I've got my finger up. So essentially, when the NHS was formed, it was formed directly after the war. So before the war, it was all private doctors, and then after the war, the NHS was started. For the NHS, when they started it, they asked the private consultants whether they would give time to the NHS. That's why they're called consultants. So they came in for a part-time. So all consultants gave a certain amount of time to the NHS. And in Australia, some of the surgeons may give 1 day to the health system. So the NHS contract with consultants was never full-time. Is that right, Taimur?
Yep.
In more recent times, has it changed, Taimur?
Yeah, so we had a change in the consultant contract, I think around about 2005, 2004, and at that point it became different, so that the number of hours that a consultant did was based on the number of sessions they worked. So a session was counted as 4 hours, which is different from the past. And the NHS said, we require you to work 10 sessions a week, which is 40 hours. But if you choose to do any private practice, we retain the right to ask you to do at least one more session. And because the NHS workload is so high, a lot of the hospitals were saying, well, actually, we'd like you to work 48 hours because that's the maximum we can ask you to work because of the European Working Time Directive. So a lot of consultants, when they were appointed as full-time consultants, but with the 12-session contract, which is 48 hours a week. Yeah. But that is mainly because of your on-call commitments and extra commitments, things like this. The 48 hours is averaged over a period of about 6 weeks. And so there will be weeks when you're quiet, there'll be weeks when you're a bit busy, and you can program these into your working diary.
Yeah. And some consultants, if they would work all weekend, that means you've got less in the week. Some consultants do a week on. A lot of the trauma consultants are in the hospital for a week and then they're off for a week. So there's lots of different, and there's part-time consultants who only work a certain amount of sessions. So there's lots of different patterns of working, aren't there, Taimur?
That's right. And I think most plastic surgeons, they will be mainly involved in their elective day-to-day work. And they will be on call for a week at a time, perhaps, or a few days at a time. And they will do their emergency work during the day. Perhaps they'll be called in at nighttime, but then that's compensated for later on. So it allows us to plan our workload for our private practice, for anything that we want to do outside of our NHS working time.
Brilliant. So Taimur, so you were an NHS consultant, head and neck. Can you talk us through the evolution of your career since then and the formation of your clinics?
Well, in 2009, I opened up my clinic because around about 2008, I said to the private hospital manager, I said, I really don't have space in my own time, and you don't have space at your hospital. So I need to find a place to seek consultations. And it took me about a year to find something. And eventually, when I found it, I built a few rooms in it, and it allowed me to consult in it. And when I did more and more consulting, I did more and more treatments, and my patients wanted more and more procedures. And it became a bit busy again for me. And a lot of the procedures that I wanted to do just as minor procedures, upper eyelid surgery, mole removal, split earlobe repairs, these minor surgical procedures that we do on a very regular basis. I set up a procedure room in my clinic, and I started doing them there. And it grew from there. So it really has been organic growth for my clinic. And while that growth was happening in terms of the surgical workload that I do, the growth also occurred in the personnel that were there. So I employed more nurses, I employed more receptionists, I started having a back office, and I started increasing the space that I had for doing various treatments and various consultations. And I brought in laser treatments as well as injectable treatments, as well as performing minor surgical procedures.
And other surgeons.
And other surgeons as well. That came more recently because the workload that I had, because what I did, a few years ago, I went part-time in the NHS, and I started doing a part-time NHS job. But it's very difficult, I think, to do part-time head and neck surgery. It's really a job for a full-time consultant. So eventually I then gave up, and I left the NHS so that I could concentrate my work purely in my clinic and in my private practice. And that immediately reduced my waiting list. But then it built up over the last few years again, and it meant that I had to take on more surgeons. Yeah. And I've asked my friends to work with me, and it's been a great experience.
Yeah, and you're not just in Glasgow now, are you? You've branched other areas.
That's right, because there were a number of people that were coming from London through to Glasgow for their surgery, and I thought, well, I'm very happy to see them, and I'm very happy to do their surgery, but these were in the days before Zoom and video consultations, and I would never really see my patients again. And so every now and then I would see a patient, but the majority I wouldn't. But the inquiries kept coming in, so eventually I thought, well, why don't I go to London, and I will rent a room, and I will see all my patients there. So for the first few months, I said to the people who were inquiring, look, hang fire, because I'll be coming down to London soon. And for all my patients that I'd done my operations on, I said to them, look, I'd like to see you again, just because I wanted to see how you're getting on. So my first few months were my clinics were full. And then it just continued from there onwards. I used to go down, I think, once a month. Now I go down once every 2 weeks, and and if I'm developing a waiting list in London, it's fine. I'm just developing a waiting list in London. There's probably not much more I can do about that, I'm afraid.
Yeah. And how many operations do you perform a year? So if we count, so Al, what we normally do, a plastic surgeon, what I do anyway, is like a local anaesthetic, like Taimur says, a split earlobe or a inverted nipple correction, something like that. It is almost like half a unit. A breast augmentation would be a full unit, and a longer operation like a breast reduction would be 2 units. That's how I sort of think of, so an operation is either small, medium, or large, basically. Taimur, would you agree with that?
I count mine in a slightly different way. I lump together all my operations, and I don't mind if some of them are small operations like mole removals and split earlobes and upper eyelids, and I don't mind if there's a big facelift to do or a complex body reshaping procedure to do. I'll just count them as one operations, and I do well. Perhaps not this year, but on an average year, I'll do about 400 operations a year. Yeah.
And will you limit it at that?
I think we're limited by time, aren't we? And it doesn't really matter if you do 52, if you operate once a week and you do 52 6-hour operations or 8-hour operations, you're still being busy. And I think most of us who are in full-time practice, whether it's full-time private practice or full-time NHS practice, we're operating all the time anyway. And so the number of operations, I think, probably, it's important, but some of us will do longer operations and more complex operations, which will take more hours. And so it doesn't really matter, I think, how many operations you do per year. It matters that you're working constantly.
Yeah. And you're quite unusual. Sorry, Al, I got my finger up first there. So I only do breast surgery really now. I've given up facelifts and ears and all the rest of it. But you, Taimur, do everything.
Yes, I think I was obviously trained in head and neck surgery. And so I'm very comfortable working around the face and doing eyelids and noses and facelifts and ears and all these other facial operations. But every plastic surgeon is trained in the body. Every plastic surgeon undergoes extensive training on breast surgery and body reshaping surgery. there's no reason why a plastic surgeon, once he has finished or she has finished their training, they can't do that. We can all do body surgery. Some of us are more comfortable doing facial surgery, and some of us are less comfortable doing facial surgery. And so I suppose I fell into the category of a facial surgeon who's very comfortable performing body surgery, and it's continued over the last I don't know, 15 years or so.
Yeah.
And have you seen a difference, Taimur? We were talking earlier to someone. Have you seen a difference between doing less facelifts now and more injectables, or do you think it's not in your practice?
I don't think it has been the case that I'm seeing less facelifts. I think what I am seeing, though, is people who want quicker recoveries from their surgical procedures in their face so that they can go back to their normal day-to-day lives. I think the facelifts that I was trained in when I was in training, some of them, they had 6-week recoveries, and I just don't think our patients can do this anymore. We all lead busier lives. We have commitments. We cannot shy away from these. We cannot disappear for weeks on end. But what we have to do is we have to do something that gives the person a nice result and allows them to get back into their normal day-to-day life. But we have to couple that with the knowledge that a facelift doesn't last forever, and the weaker the facelift, the more mini the facelift, the less longer it will last. But that doesn't mean to say you need another facelift. That just means to say you need your maintenance therapy. You know, I like my cars, and the both of you know that. So I often think of it as, you know, if you're buying a nice car, if you're buying a nice new car, you got to take it to the service center every 6 months, every year. And if you take it for a service, then it's going to last so much longer. But if you just drive your car, you never change the oil, you never change the tires, you never check the engine, then it's not going to last as long. And I think facial surgery in combination with non-surgical aesthetics is analogous to that.
Yeah,
I think you're right. I think an analogy that I quite often use with ladies is, it's a little bit like sometimes patients will say, oh, well, I'm not old enough yet, or I'm not this, or I'm not that. But as I say to them, you don't let your house fall down before you start redecorating. And the reality is you just have to kind of keep doing it, I think. And I guess the great thing for you though, Taimur, is if you not pick someone up, but if a client, say, comes to you in their late 30s, early 40s, you can do all of your non-surgical, and then hopefully they eventually stay with you to surgery if they need it, I'm guessing.
Well, I think my job is to keep me and my knife away from my patients for as long as possible. And sometimes we have to do something. Sometimes you've got to rebuild your house. Sometimes you've got to change your car, but you'd rather service it, and you'd rather do little tweaks here and there just to make someone keep someone looking their best.
And the Belle Forme offers, all car services, doesn't it? You can get your seats redone, you can get your exhausts and your new tyres, and you can get a respray if you want. Yeah. It's
an MOT centre as well.
Yeah. So Taimur, could we delve a little bit into your business career? Because as we mentioned before, you've got very good clinical credentials, but what perhaps is rare is to find someone with such good business credentials as well. So can you talk us about the growth of your business and some of your tips?
Well, they say necessity is the mother of invention. And when I was finishing my NHS training and I was about to start becoming an NHS consultant, what happened was that I went to work in Oxford. And I went to work in Oxford for the last year of my training before I became a consultant. And in Oxford, my rent was a bit high and my income was a bit low. In fact, there was a £100 difference. So what I was earning and what I was spending on my rent, I had £100 left, and that was for my electricity bills and looking after my 3 kids and things like this. So looking after my family. So I really had I budgeted that into my training. Because, for a few years to come, in a few years' time, I'm going to be doing a fellowship. It's going to cost me a lot of money. I think I'll save up.
Can I just say something? Just that. So in most careers, you start earning money when you're quite young. But in plastic surgery, you only really start earning any money when you become a consultant. And I was 38. How old are you, Taimur? when you?
Oh, Adrian, I was 35.
Oh, how annoying is that? Yeah, yeah, because we are sort of contemporaries. Although I think you're a bit younger than me, aren't you, Taimur? I think
We're a few years difference, aren't we?
a few years, yeah. But basically, when I was 38 and I had my first job, I had no money. I had no house because you move around. I had a loan. You know, you know, you don't realise that there's an awful lot of time before you can. You're not financially secure at all.
And I think as doctors, we don't care about that. We're not interested in earning heaps of money. We're interested in other things. We have other priorities, and as a result, I used to say to people, "I'm the only broke plastic surgeon in the country," and people used to laugh, but really I was, because I maxed out on my credit cards. I spent all my savings. I borrowed some money from my mom, and I really had to pay all these things back.
Taimur, you still owe me a tenner, actually.
Yeah, you owe me a couple of copies as well. So
anyway, so back to your business career.
So I was the only broke plastic surgeon in the country, and I really had to do something about it. So I started working in private practice. I gave myself about 6 months or so just to set my NHS practice up and to be comfortable with it. And then I launched my private practice because I asked the insurance companies, how much will it cost to insure me? And they said, well, it depends on your earnings. So I asked them, well, if I earn this much, how much will you charge me? And it wasn't worth it. And I eventually asked them quite a few. I asked them for their different brackets of indemnity cover versus earnings. And I realized that actually, in order to earn any money to pay off my debts, I really have to launch myself into my private practice. And so that's what I did. And obviously it snowballed from there onwards.
Yeah, tell us a little bit about that. Sorry, can you tell us a little bit about that, the snowballing effect? And Al, were you going to say something?
I was just about to say, was that then the formation of Belle Forme?
Yes. So to begin with, it was, I just went to the private hospitals and I said, look, I'd like to have space in your consulting rooms. And about 2 years later, it snowballed to the point where the space in the hospital was not meeting my wishes. They had space available, but not when I was free. And so it just couldn't work out. So I had to take a place where I took a room, and that's where I formed Belle Forme.
But you've got more than one, isn't it? Tell us about Belle Forme. There's more than one, isn't there?
Yeah, so Belle Forme. So I took on another clinic in Glasgow, in the south side of Glasgow. I took on a clinic in Kent, and I took on a clinic in Essex, and I started working in Harley Street as well. But then I was just spreading myself so thin that I think I realized, well, I probably just have to consolidate what I'm doing, and I'll just consolidate it into two areas. One would be in Glasgow, one would be in central London. So that's these are the plans for Belle Forme. I think it's nice to grow and it's nice to expand, but fine well from in our industry, in surgery and in non-surgical aesthetics, we develop relationships with our patients, and patients want to see us because they want to come and see you, Alison. They want to come and see you, Adrian. And so spreading yourself then becomes probably a little bit difficult in our industry when it's a personalized industry. Whereas if, on the other hand, you could say, well, you're getting the same level of service no matter where you go, and all the staff are peers for one another. We support each other. We go on the same training courses. I train for Allergan, so they come on these courses. And you could say that, but I think we develop relationships with our patients, don't we? And what we do is that's what we do.
Yeah, and Taimur, are we allowed to talk about your latest plans?
Or whatever you want. Yeah.
Yeah, come on. So tell us about your latest project.
Well, my latest project, I suppose my latest project is in distribution and supplies.
That wasn't the one I was thinking of.
Oh, what
well, the mini hospital you built in Glasgow.
Oh, the hospital, yes.
Yeah.
Well,
that one.
No.
Full well, what happened with La Belle Forme is that, so I started that in 2009, and I took on a lease of a premises in 2009. And the lease ran out 10 years later. And I extended it for a short while. But then I just thought, well, what I started off is not what I'm doing now. And what I'm doing now is I'm doing much more surgery. I'm doing much more invasive procedures. And I just wanted to make my patient experience to be as high as possible. Because at the original location for La Belle Forme, patients would come into the waiting room, they would have their surgery performed, and then they would go out into the waiting room, and then they would be picked up by their responsible adult, and they would go. And whilst this is okay for walk-in, walk-out procedures, I was beginning to do more and more invasive procedures, and I just thought, well, maybe we could have a room for the patients to stay in. And of course, we had that in our original place. But I just thought it'd be nice for them to have their own room, and it would be nice for a different patient journey. And
so, is that why you built a hospital?
Yeah, that's right. I came up with a design. I came up with I found a place, and I thought this is the way patient flow should be. So a patient should come in here. This is where they should go. That's where their next step is. This is where they should go after that.
And I believe, Taimur, you've travelled around the world, seen different operating units, and tell us what you've learned. And also, could you tell us the size of your facility?
Well, the facility, it's the size of a gym. So it used to be a gym, and it used to be one of these 24-hour gyms where you just press your card in. So it's there are some really big gyms that have got swimming pools and tennis courts. So it's not the size of one of those. It's the size of a gym with weights and machines. And
how many square meters?
Oh, 700, 800, something like that. So
how big are the glass houses, Al?
I know the 9 square feet we are.
So you divide it by 10, or you multiply by 10.
Multiplied by 10. So we're 900 square feet in Clapham, and Wimbledon were 1,200.
So that's 120 square meters. So Taimur's is 8 times as big as yours.
Yeah, bigger.
Bigger.
It's a big facility, but I think you need a big facility if you're going to do surgery in it, especially if you're going to do general anesthetic surgery.
Sorry, Taimur. So I was very interested when you told me how you've split your space up. Could you? So you've got a big open space. How are you going to, you can choose anything. How are you going to split it up?
So we split it up into 3, and we thought we have a left-hand side, a right-hand side, and an upstairs. And so on the left-hand side, we're doing consultations. It's our room area. We're doing Botox, fillers, lasers, non-surgical treatments there. We can do consultations there as well. On the right-hand side, we've got the operating suite. So you walk into the right-hand side, and you enter a public area. Then you go through some extra doors, or you go through a changing area, and you come out into the clean facility, which is where the operating theatre and the surrounding areas and the surrounding rooms are. And we have a recovery area or a post-anesthetic care unit, and there are discharge areas for patients within that area as well. So the hospital is set up in 3 different areas. We've got our operating suites, and that's where the operating suite is working. And I suppose I've taken examples, and I've learned from what I've seen, where I've worked at, so that I could make the experience for our patients as comfortable as possible.
So 3 areas: so an operating area, a non-surgical area, and what was the third area, Taimur?
Third area is more administrative. So we have an administrative center. We were always running out of space in our kitchen at our original La Belle Forme. We were crowding in. All our practitioners would be there. It's the only opportunity we have to see each other and have a catch up because our diaries were so busy, and it's nice to have a nice, relaxing, open area where we can sit and chat to each other.
Yeah. So Taimur and I sort of set up our clinics at roughly the same time. So Taimur was the Belle Forme, I was Aurora Clinics, and we probably built it up similar sort of size. Taimur, would you say?
Yeah, my first clinic was 3,000 square feet, so 300 square meters. What was the Aurora clinics in?
Well, we had a couple of facilities, and we basically were in an old BMI hospital, which there was a covenant on it, so they couldn't sell it because the old lady who'd owned the building said it had to be medical. So we had a lot of space, and it worked. It did work really well. But we went. So the problem for me was I developed a big team really, and we went to a works night out, and I've got a picture of me surrounded by 30 staff, basically 30 women, and they were all lovely. And we had a lot of surgeons working for us, but I was doing the most work, but I was also the worst paid surgeon. So I know you do the same thing, Taimur. So you have other surgeons, but you are paid less probably than the other surgeons, or equivalent. Is that right?
I think we earn it. I think most people, we just want to earn enough to maintain the lifestyle we have, and if that means we earn a little bit less than perhaps someone else is earning, it doesn't matter, because we're building things, and sometimes we see our sense of achievements in things other than monetary achievements. And
I think so, and I think also the difference being also is that those people that you employ, or that we employ, when they leave the business, they leave the business. They don't take anything with them, they leave. Whereas for us that have created businesses and built businesses, when we decide to leave the business, we then have something to pass on or something to sell on. And I guess that's the thing, isn't it? That's what we're all trying.
Yeah, but that isn't always the case, Al. So there's and Taimur, I know will agree with this. There's a number of very famous plastic surgeons who've just been in solo practice. So we know them, don't we, Taimur? So when they leave, when they decide to retire, there's nothing to pass on.
But that's where you've got to create the business model that I guess we've all created, that there is something. So we have a structure to pass on.
Yeah. And Taimur, I know you sort of create an ethos. I know where you both do, Alison and Taimur. You're sort of the leaders of the team, but the team following your ethos of where patient care is number one.
Of course, that's right. And that's just because, Adrian, just because you may buy an Armani suit and I see you in Gucci, Armani and Valentino, just because you buy an Armani suit doesn't mean to say that Giorgio got his scissors and cut that cloth for you.
No, that's true, actually. But we've talked about it, Al, haven't we? How it's difficult. It's difficult to manage. As you get better known, more people want to see you, and I think the difficulty we've all got is how to, manage that. How do you do that, Al?
Well, it's difficult and it's a challenge, but I've tried always to keep it as the glass house. So people know me professionally, I think, within the industry, but I take it as I'm really pleased when people ring up and say, oh, can I make an appointment? I'm a new patient. And the girls might say, oh, I'm really sorry, Alison's not available. And then a patient says, oh, no, it doesn't matter who I see. I just want to see someone. And that, I think, is the best thing that I can achieve when I've got patients who are happy to see anyone within my team. We do have other nurses, but it is difficult to move patients over to them. But I think this COVID, if anything's come out of that, is that when I go back, I want to change my working patterns, because I have just...
Yeah, well, Al, so I've heard there's quite a few of your patients that I've met who actually are requesting the other nurses now.
Probably. Yeah. That's all right then. That's fine. Yeah. That's absolutely fine. So I think that's what it is, isn't it? It's creating a brand of your brand, so that if you're not in it, it doesn't matter so much. What I always do find weird though is when I have patients in the building and I don't know who they are, because they are seeing the other team members.
Yeah, that's
always a funny one, because I don't know who they are. And actually, when I opened Wimbledon, which was really interesting, when I did my first clinic there, I went out and greeted the patient and brought them in from the waiting room, and they bizarrely said to me, oh, we didn't expect to see you, because they just thought I owned the clinic. They didn't realize that I was still working in the clinic. So that's brilliant too, if patients don't expect to see me.
Yeah.
Because what that means is we can then all start to have hobbies, which moves us nicely onto Taimur's hobbies of fast card.
But Al, before we do that, so the new hospital, is it open now, Taimur?
We got 1 week of building left to go, and obviously when we are released from lockdown, it should be ready shortly after that.
Yeah. Can you do anything in lockdown now? Is anything happening, or can you get any building done now, or not?
No, I think Scotland is slightly different to England in terms of the devolved nature of the lockdown laws, and so we have to listen to the Scottish government, and they're still saying to us, "Don't go back to work." Unlike the Westminster government, which is saying in England, if you can go back to work and if you can go back to work safely, now is the time to do so.
Yeah.
In Scotland,
okay. And before we go on to Taimur's hobbies, which I know you're very keen to get onto, Al, you mentioned your distribution side of the business. So can you tell us a bit about that, Taimur?
Yeah, well, I suppose we've all been thinking, what are we going to do when we restart, and how are we going to change our practice? What are we going to do to protect ourselves or protect our staff, protect our patients? And this is something that a lot of us have looked into. And so I looked into these things, and I looked into buying some protective equipment for myself, for my staff, for my patients. And either they were out of stock, or the prices were inflated to about 4 or 5 times what we're normally used to spending when we're buying these things. So I went back up the supply chain, and I found some manufacturers. I found a warehouse. I found some friends, and we're now importing directly from the manufacturers. Obviously, we've got to buy at wholesale quantities, and in other words, we have to buy several 100,000 or 1 million at a time, and it takes a few days for them to arrive into Britain, and there's a bit of a risk, are we getting stuff that's good quality or not? But when we do, and when we get some good quality stuff, then we know that there's no shortage of materials available.
And what are you buying, Taimur?
Well, it's anything that a clinic is likely to use. So face masks, face shields, gloves, hand sanitizers, hard surface wipes, surgical gowns. These are the things that we wear as part of our normal day-to-day practice. And these are the things that are becoming short of supply.
I think what you should do, I'm sure you're probably doing this anyway, is you should have a non-surgical clinic kit, so that, because people are all confuzzled as to what they're meant to be having. So if you say, right, if you're performing Botox and lip fillers, you need this, and it has your correct mask, and kit A is that. And then you have if you're doing lasers with a plume, this is your kit. You probably already thought about this, Taimur, but I think that's a brilliant thing. And also, because I tried yesterday to buy masks, and I was being quoted 120 masks for £600.
Okay, so what's that?
£5 a mask.
£5 a mask. I think £5 a mask is a bit expensive.
So if you could let me know, then we can buy through you.
Yeah. Taimur, can you just...
£5 is I know what the prices of these masks are, and £5 is just, I think it's a bit, that's robbery.
Profiteering.
Yeah, but Taimur, there's masks and masks, aren't there? So could you quickly talk us through all the, the different types of masks, the FP2s, 3s, and all that sort of thing?
There are 3 types of masks that we need to consider. There's normal surgical masks, which we would wear when we're trying to prevent ourselves from infecting our patients. And when we speak and we generate aerosols, we generate air coming out of our bodies, these masks provide a degree of protection against someone who is in close proximity to us.
So, but basically, Taimur, so they say if you can smell garlic on someone's breath, you're too near them. Yeah. Okay. And if you wear a mask,
okay, you probably disappear back into your cave and.
yeah. But if you've got a mask, anything you breathe out basically is held there, and the area where it goes distribute is smaller. Is that correct?
That's right. It's supposed to bounce backwards, so that you don't breathe on top of on top of one of your patients, or and you don't pass your infections onto them. But
so a surgical mask is to reflect the air backwards so you don't breathe on. So, so there's supposed to be a gap, whereas those, the PPE masks actually are tightly fitted, aren't they?
They are, and they're much more protective to the wearer. So they're called respirators, or they're classed as respirators. And so there are two main types of respirators. There are those that are in America and in parts of the world they're called N95 masks, where they, and the UK equivalent is FFP2, where they filter out 95% of the, oh, there we are. Now, what have you got there? You have got, is that an FFP3 respirator? So for masks, there's two types: the 95% filtration ones and the 99% filtration ones. The 99% filtration ones, they probably are best used in hot areas of coronavirus, where you really need to be very careful about the amount of aerosols that are being generated. For example, if you're drilling bones, if you're drilling inside the mouth, as dentists will be doing, these are the things that you probably want to be worried about. If your patients are coughing in there and their masks are being, gosh, Adrian, you look so much better. You need to say something, then we can see you on video. So there of the FFP2s and the FFP3s, there are two types of something that can go in the front. Some of them are plain, and some of them have got an expiration valve. In other words, yeah, that looks like it's got an expiration valve. So if you're breathing out through that, you're still going to breathe on your patients, but they're not going to be able to. You're not going to be able to breathe in from them.
So this is more protecting you. So basically, this one someone gave to me. So the mask is the normal mask, but it's got the goggle attachment as well. This is more to protect you, whereas a surgical mask is protect other people.
Yes, that's right. And there are two types of I want to protect myself type masks, and there's the 95%, the 99%.
And what should Alison? Which ones are you looking at in your clinic?
The FFP2 and the FFP3 is what the JCCP guidelines are suggesting. What are your thoughts on that, Taimur?
I think FFP2s are going to be sufficient for the vast majority of treatments that we perform.
Okay.
And because the FFP2s are sufficient, I think we probably want to find the best possible price for these, because we're going to be using them on a daily basis. We're probably going to be changing them every day or two. And because we're going to be using high quantities of them, we don't want to buy things that are £5. We don't want to buy some things that are £10, because, and I've seen them for £20 as well. These are ridiculous prices.
Yeah. So this says FFP3 in small letters.
Okay. Yeah, that looks like an FFP3 mask, to be honest.
So this is the one people would need to use for intraoral treatments.
I think if you're a dentist and you're drilling teeth, that's what you want to do. If you're creating a lot of aerosols as part of your procedures in and around an area which is going to be potentially riddled and with coronavirus particles, then I think that's what you want to use. You want to protect yourself as best as you can. I suspect dentists are going to do that. I suspect we as surgeons, we're going to use FFP2 masks. And I think as injectors, we're going to use FFP2 masks. I think our non-patient contact personnel, people like our receptionists, our office staff, I think they're going to be wearing normal surgical masks. They're called type 2R masks. And I think our patients will be coming in and they'll be getting their facial injections. So ideally, we would like our patients to wear masks, but I don't think it's going to be possible for them to wear masks and for us to treat them at the same time.
So with the mask then, Taimur, you don't have to change them every patient?
Not the FFP2 masks.
Okay.
Your gloves usually obviously should change in between each patient, and masks. And if you're wearing a hat or if you're wearing a uniform, you can keep them on all day. Surgical masks, people tend to change them between each patient just because they lose their efficacy quite quickly. But to be honest, I don't think the surgical masks are going to be providing us as healthcare workers with the level of protection that we want to protect ourselves, because when we protect ourselves, we protect our patients.
So if Alison was injecting in a day, she could use the same FFP2 mask throughout the day.
Exactly.
Brilliant.
Oh,
and how do people if anyone's interested, any clinic practitioners out there, Taimur, how do they contact you?
You mean what's my website that I've set up?
Yeah. Yeah.
Well, I mean, obviously, I don't want to advertise, but you go to clinicsupplier.co.uk. I've put everything up there. If anyone wants to have a look, they can see it. If anyone wants to buy wholesale, then they contact me. So there's a wholesale side of the business which I've started, but I'm just taking small quantities, maybe 1,000 at a time, and I'm saying, well, that's for retail.
So you haven't bought 1 million of anything?
I'm about to buy 1 million.
Oh, yeah.
But I'm sure there was a young guy, this was on Instagram, he'd gone and bought something like 1 million little things of hand sanitizer, and then he was selling them online, and he got stopped from selling them online.
I think hand sanitizer is different. Well, I don't know about the details of the case, but there may be a number of reasons why this would have happened. One is maybe he was just profiteering from this.
Yeah, I think so.
Secondly, hand sanitizers, they've got 70% alcohol. If you stick them in the post, it's an explosion risk. And so you can't really send hand sanitizers in the post. You've got to have courier delivery. You've got to have land delivery. You've got to drive the product from one place to another. So whilst we can, and the only reason I know this, you suddenly find these things out. The only reason I know this is because
one blew up.
On my face.
Yeah. You had hair before. Yeah. Last time I saw you, you had a lot of hair.
Yeah, I hadn't shaved that day, you know.
Yeah. Anyway, so Al, shall we move on to your pet subject, which is racing cars?
Yeah, well, I think how first of all, how do you have time for it, Taimur, when you're setting up hospitals, setting up distributions, and injecting? Yeah, come on, let's talk about what you do outside of work, Taimur. And also, just going back, quick interlude, this doesn't have to be on the podcast. You talk about the picture of Adrian surrounded by 35 women. I'm sure on Facebook, Taimur, I've seen you surrounded by your very glamorous team.
Hmm.
I employ people according to their skills. And,
yeah, we all do.
Yeah, how many staff have you got now? How many in your team, Taimur?
I think there's about 30 or 40 or something like that.
Yeah.
Sure, we have a similar, Aurora and Belle Forme are similar in size, aren't they?
Yeah, well, I'm small now. I'm just on my own now.
Yeah.
So anyway, moving on. Yeah, so Al, you're into cars, Taimur's into cars. Yeah. I'm an old granny driver, so...
What do you drive, Adrian? What do you drive, Adrian?
Well, I've got 6 vehicles.
Go on then, what have you got?
I've got a tractor, which you've seen, I think. I've got a Land Rover with the top off, a long wheelbase one I drive. I've got an S2000, which you know what that is, don't you, Taimur?
Yeah, it's a Honda.
It's a Honda with a very high, very special car. What else have I got? I must have something else. Oh, and I've got various farm machinery things. Yeah. But nothing that fast. But I used to have a caterum like you, Taimur.
What did you? When did you stop having a caterum?
Well, what happened is my brother-in-law had it, and it was a dry sump caterum, a racing caterum, and it's scary to drive, isn't it? And I'm a bit cautious with speed, I think, whereas I know you two are a bit more, so it basically scared me. Because you would go up to a roundabout. So my brother-in-law, when he showed it to me, you go up to a roundabout and you don't brake, do you? And he went around the roundabout at 60 or 70 miles an hour. Scared me, really. So that's when I got rid of it.
Well, I have a caterum as well, and I use that as my main track car. And I've modified it. I've changed the engine, given it more horsepower. Caterum's grip around corners really nicely, and so if you're on a racetrack, it's a lot of fun because you can go around the corner very quickly. The frustrating thing about a caterum is that when you're on the straights, all the supercars are overtaking you, and so I just changed the engine to give it a bit more horsepower, and I'm gradually increasing the horsepower as time goes by, just so that I can get faster and faster on the straights.
How many horsepowers have you got now?
I think it's about is it 250 or something? So the car weighs very little. Your average car nowadays weighs about 2 tons, and each room weighs just over 500 kilograms. So it's about a quarter of the weight of your average family saloon.
Yeah. So it's all about power to weight ratio, isn't it?
Yes. So to add speed, you add lightness, and the lighter your car, the later you can brake because it doesn't have such a heavy thing to brake. And the faster you'll speed off because it doesn't have the inertia, and the engine doesn't have to work so hard to propel something along because it's so light. If you look at a fly, and if you compare that to an elephant, a fly will zip off very quickly, but the elephant will eventually catch up with speed. But it's going to be really hard to stop the elephant. But stopping a fly is easy. The lighter the car, the easier it is to change direction.
Yeah, and Alison, can you tell us what a horsepower is? 1 horsepower.
It's it's to do with the strength of the horse that would be used to pull.
Is that correct, Taimur?
I'm a metric man. I know what PS means.
I think it was when they moved to horsepower. You needed this engine would replace 1 horse, basically.
Yeah. Exactly. Yeah. I did vaguely know that, you see. And also, with your racing, are you racing like competitively against people? What are you doing with this?
Well, there are 3 things that you can do when it comes to driving a car on a track. You can just go on a track day and you can just enjoy yourself, drive as fast as you want. And that's generally what I do. And there are 2 types of racing. There's solo racing. In other words, you're racing on your own against the clock and you're trying to get the fastest time. And then someone else does the same thing, and then someone else does the same thing. So you're on your own on the track. And there's competitive wheel-to-wheel racing, where if someone else makes a mistake, suddenly you crash. So I don't really want to do that. I don't want to be the cause of an accident where I ruin someone else's car, nor do I want someone else to be the cause of an accident where they ruin my car as well. So I'm a bit wary about wheel-to-wheel racing. And I do it more as a hobby because I enjoy it rather than I want to compete at it. And so I'm much happier just going on the racetrack and just looking at my own timings to see what I can do as my own personal best.
And I think I saw a great picture of you driving around the Highlands in your McLaren?
Yeah, so there's the North Coast 500, which is a beautiful drive, and it passes some lovely scenery in the north of Scotland, where you see some beautiful cliffs and really lovely beaches. Obviously, the water is absolutely freezing, so you don't really want to dip your toe in there. But it's very pretty to see, particularly on a sunny day.
Yeah, brilliant.
I went on the North Coast 500.
Yeah, so maybe we could all go on that together. Alison?
Yeah, I think it's amazing. It's the northwest coast, isn't it? Does it start on the northwest and then go?
It starts in Inverness and it goes up to Wick and John O'Groats, and then it crosses the very top, the very hat of Britain, as it were, and it goes down towards Skye and towards the west north coast of Scotland, and then.
Adrian's getting a cup of coffee.
And then, can I have a cup of tea as well? And then eventually it moves back to Inverness. So it's a 500. It's not really a 500-mile trip. It's more about a 600, 700-mile trip, just depending on where you decide to stop off and how far off the beat, how far off the beat track you.
But you can stay in some beautiful places on the way, can't you?
Oh, for sure. And you can take little diversions as well. So it's lovely.
Exactly. In fact, Taimur and I share the same accountant, I think, don't we?
Oh, Ian.
Yeah.
Okay. Oh, yes, because we were talking about accountants, weren't we?
Yeah, we were. And we share the same accountant. And the lovely thing about Taimur, I remember, I've always respected sort of Taimur's sort of thoughts on things. So I remember sending you an email a while back saying, Taimur, I'm looking into getting fat freezing and da-da-da-da-da. Could you advise me which you think is the best platform for that? And you said, well, put it this way, I'll sell you this particular one because I want it out of my clinic. So I knew that wasn't the one to buy.
That's when I started thinking, maybe I could distribute and supply stuff.
Yeah, exactly. Yeah. I tell you what you could do, Taimur. I think there's a definite, talking to colleagues at the moment who are talking about going to work slightly differently. Some colleagues are wanting to offload their equipment now. I think
that is interesting. And is that because they feel they're gonna have a different way of working, or they want to downsize their practices? Why do they want to get rid of their equipment?
I think I think what's happened is everybody has looked at their practices and thought, right, if I've got to go back, what's my most efficient way of working? What's going to be the most profitable way of working? And also, do I want to go back in the same form? I think there is a lot of that.
You know, at times of recession, you can do one of two things. You can concentrate on your core, and I think that's what people are doing. Or you can start diversifying your income streams, and you can start diversifying. You can create a greater breadth and a greater depth of what you do. But I think
what was interesting, before the Great Depression in America, there were I think over 300 car manufacturers in America, and at the end of the Great Recession, there were only 4 existing, and they were the 4 that GM, Chrysler, the car manufacturers, the ones that have stood the test of time for the last 100 years. So it's a difficult time, but I think you're right. The ones that do come through will come out probably stronger.
So do you think what's going to happen after lockdown with cosmetic clinics? Do you think the ones that have very small practices, do you think they will continue, or what do you think?
I've got a friend who's in Guildford, who's a successful practitioner, and she doesn't think at the moment she can go back to practice as a single person. Whereas you're slightly different now.
Because she won't be able to. Well, it's interesting because actually I've been talking to the girls we've been sorting out with the team today, and because I've said, what's the demand? Because there's a huge demand for injectables, but the demand for the therapist treatments is that's not coming back in so quickly. But I guess the way that we're going to practice, and this came a little bit from when we were talking about Adrian, is because I've got 3 rooms in each clinic, then I will work out of 2 rooms, because that means that I can see patients in reasonable sort of timely, and then the therapist will work. But I think it depends on how you've run your business. I think if you've run your business hand to mouth, and you've bled the business dry, then I think it's going to be hard to go back, because there are going to be costs and all of that kind of thing. Whereas I think if the business has been in a fairly safe place before, and you go back sensibly, then you should be okay. So why is this person saying they don't think they can go back?
Because she doesn't see how she can treat intraorally safely, or how she can do treatment around the mouth safely.
I mean, like lip fillers?
Yep.
Yeah, I think that is something that is a concern. But I think, there are people who will do lip fillers, and there will be dentists who will drill in the mouth and drill in the teeth, and the level of safety still has to be equivalent, so that the person performing the treatments gets as minimal an exposure as possible to the virus particles. So I think when we go back to work, yes, we will be working differently, but I don't think it's going to be an insurmountable hurdle whereby we have to stop our practices. I think it's still going to be possible for us to wear FFP2 masks and confer ourselves the degree of protection with which we are comfortable.
Yeah, I 100% agree. So what I think, Al, you made a really good point. So there's a lot of companies who don't have a cash buffer. So if you are a company, when I ran Aurora, I was talking to an accountant, he says, you'd really have 3 or 4 months or cash buffer available. And if you're a company you haven't got that, it is difficult, as you say, Al, to carry on trading. We've still got the rental on all the buildings. So we have 3 big buildings which are empty, which we're paying rent on. So if you are in that situation without cash buffers, I think it can be a problem.
Yeah, I think so. I mean, we've carried on paying all of our rents, partly because what I didn't want is to go back and have the landlord saying, right, now you've got to sort of back pay. And so I think, but it just depends how you run your business, doesn't it? Anyway, this is probably a conversation for another time.
Yeah. So Taimur, it's been an absolute privilege and very entertaining chatting to you. Any last thoughts before we say goodbye?
No, it's always.
I'm going to go on.
And it's great to see you again, Adrian. It's great to see you again, Alison. Haven't seen you in ages.
So you guys are on the Allergan. Yeah, where you guys are on the Allergan faculty, don't you? So you teach mutually in the same environment, don't you?
Yeah, but have you been doing much teaching recently,
I
Taimur?
think I'm going to do a journal club for Allergan, and I
Oh, okay.
did some teaching for plastic surgeons in terms of fillers towards the end of last year. But I think a lot of face-to-face teaching and the traditional way of teaching, you know, the 5-to-1s, the 15-to-1s, where the attendees bring in their patients for doing treatments. I'm not sure I'm not sure how that's going to continue for the future, and maybe that's one of the reasons why a lot of clinics are going to be asking themselves how they're going to continue, because training is going to be very different from here onwards, isn't it?
Yeah, I think the world is going to be different, isn't it, Al? And you know, we don't know how, but it might be good to revisit this in a couple of months, you know, and see, you know, where we are.
Yeah, I mean, I think, and this is chatting to, I think Harley Street's going to be hit really hard, because especially for non-surgical, surgery might be different, Adrian, for you, I think, but non-surgical, you know, our people, if they're not going back to work in town and they're working from home, like the big banks and lawyers and everything, they're not going to be in town to have their appointments. And are they going to travel into town to have them? So I think Harley Street's going to be hit really hard.
Before we go, yeah, that's a very good point, Al. I think, I hadn't thought of that. It's a good point. Before we go, would you like to see my mug?
Yeah, go on then.
I actually want to see a tractor, but there we are.
Hey, do you want to see my tractor?
Yeah, go on.
I can't show it to you now, but
send me a picture.
Yeah, it's got a scoop on it. I've got a scoop, and I've got a topper. Do you know what a topper is? A topper's big mower you put behind.
Okay.
And the other day, I'm like a gentleman farmer. I don't really know what I'm doing, really. But so the other day, I ran over my wife's long gardening hose on my first outing with the topper. And then I plugged in I got a trailer which lifts up automatically. I plugged it in, and as soon as I went to do it, the hose went spurting hot oil all over myself, my son, 5 minutes before I was doing an Instagram live. So I'm trying my best, but these farm equipment is a little bit complicated, but I'm getting better. This is my mug that someone bought for me. So one of our staff runs a shoot. So it's me with my pheasants. Shall I show you the other side?
Yeah.
Do I dare?
Yeah.
It was a friend of mine who gave me that. Do you understand?
Luckily, there's no old birds in the room.
Exactly. So, guys, thank you very much. Al, any last parting comments?
No, thanks, Taimur. We'll this will now be cut and trimmed so that it sort of flows really nicely. And then
nicely anyway. Hopefully, there won't be so much editing that needs to be done.
No, so. And we'll obviously send you a copy. So brilliant. Hope to meet you soon in person, Taimur, and maybe we could all go on that. What's it called? The Scottish 500.
500.
North Coast 500. Yeah.
Brilliant. I'll be at the back of my tractor.
Yeah.
Great. See you all, guys.
Bye.
All right. Bye.
Yeah. Bye, Taimur. Bye.
Bye.